All right. Hello, everybody. Give us a few minutes. We're gonna wait and allow people to sort of file in because it's it's a minute or so before the hour, and then we'll get started. I'm gonna drink a little. Sorry about that. I had to kick out my cat before we get started. Otherwise, we'd have a whole transcription of cat butt. So like I said, we're going to give it a couple minutes for people to come in, and then we will get started and start talking about hormone replacement therapy, everybody's favorite topic, at least at Genève. All right. Well, I'm going to start with just some introductions, introduction to the series, introduction to my guest who's here with us today. So for those who don't know me, I'm Rebecca Dunsmoor-Su. I am the Chief Medical Officer at Genève.com, and we are a 50-state telemedicine group for perimenopause, menopause, and midlife. We have a phenomenal team of physicians who work with us, all of them menopause expert. And we also have a phenomenal team of registered dietitian nutritionists who work with us, also menopause expert, and really help support women through this time of life and think about long-term health. One of the things we do at Genève is work with hormone replacement therapy, among other therapies, to help with symptoms and health outcomes. And so we thought that we would kick off this inaugural series with a conversation about some of the more complex ways that we talk about hormone replacement therapy. The goal of the Menopause 201 series is for providers to attend and get some more in-depth information on subjects around menopause that maybe weren't explored in your training or that are coming up over and over again. And those of us who have done this for the last 20 years might have some insight to help with your counseling and your care of patients. And so I'm thrilled to introduce Holly McArthur. And Holly, why don't you tell us a little bit about yourself? She's one of our Genève physicians.
Hi there. I am in Asheville, North Carolina, and I've been in private practice in Asheville for 26 years. And I've been with Genève for a little over a year now, and it's been a really great experience because it gives me more contact with menopausal patients who I feel like I can really make a difference in caring for them. So I'm happy to be here today and answer any questions that you guys might have about managing menopause and some complicated patients.
Thanks, Holly. We are going to start by having just a quick conversation between the two of us and addressing a couple of topics, and then we're going to leave a ton of time for questions and Q&A because I think oftentimes everything we say makes more come up. And so we really want to give you guys plenty of time to ask us questions. And if you want to put them in the chat or in the Q&A tab, we'll address everything. We'll address some of them as they come up, and then we'll get to everything by the end. So I was going to start with Holly, you and I talk about risk with hormone replacement therapy all the time. And the risk that patients come to us afraid of is breast cancer. And I think all of those patients have heard of the Women's Health Initiative. They may not understand the statistics from the Women's Health Initiative, but they've heard, oh my God, hormone replacement therapy. And sometimes they even say estrogen causes breast cancer. What things do you find useful in talking to women about that risk, and how do you frame it for them?
Yeah, that's a really great question to start with, because I think that's the question that women come to us with that in the forefront of their minds. And so I always start out by reminding women that breast cancer is common. Most women are familiar with the statistic that 1 in 8 women will get breast cancer, and that's if you live to be 86. So that means that breast cancer is going to happen in women who are not on hormones. It's going to happen to women who are on hormones. And that doesn't mean that there's causation there. So I also review that breast cancer is very treatable if caught at an early stage. And I make sure that they are up to date on their screening and make sure that if they have dense breast tissue, that they're aware of the option of having an MRI or a contrast enhanced mammogram to enhance their screening. If they have family history, I make sure that they have had genetic counseling or genetic testing if that's appropriate, or have that option presented to them. And then, like you alluded to, Rebecca, I think that the risk of breast cancer being in the forefront of our minds is really from that Women's Health Initiative study in 2002 that presented that data in such a way that it seemed like it was a pretty dramatic risk. So I like to kind of dive into that data with women because I think it's important for them to understand where that came from and what it means. And I tell them that in that study, the risk of breast cancer was not found to be statistically significant. So I tell them that if your risk of breast cancer is the same as your next door neighbor, that risk is 1. If your relative risk is twice your next door neighbor, your risk is 2. And that in that study, the relative risk was 1.2, which is not considered to be statistically significant. And my experience is that most women find that kind of puts it in a context that they can understand, that doesn't seem quite as dramatic as what they might have originally thought. The other piece of information in the Women's Health Initiative study that I get into is the absolute numbers of breast cancer risk increase, which was an additional 8 out of 10,000. A lot of you guys probably already know that number. So that translates into roughly an additional 1 out of 1,000 woman years additional breast cancer. And I think to put that in context, if you ask women about some of their just regular lifestyle habits, there are probably some things that they're doing that might be more risky than hormone therapy. For instance, a daily glass of red wine can increase your risk of breast cancer by an additional 2 out of every 1,000 woman years. And then red meat consumption can increase your risk 5 to 8 out of every 1,000 woman years. So I think that kind of brings it home that breast cancer with hormone therapy is not such a significant increased risk, although certainly something that they should be aware of.
Yeah, I think that's great points. Thank you for that.
Yeah. I was going to say that the risk of progesterone in that study it was felt that the risk of progesterone was probably the increased risk with breast cancer, and that we have new medications and more data that supports the use of different progesterones. So micronized progesterone has been shown to not increase that risk of breast cancer in some studies. And then I bring it back to what their personal pros and cons are. So I think that when women hear this theoretical potential risk of breast cancer versus the things that they're experiencing on a daily basis with disruption in sleep and sexual function, that they're able to put all that data together and decide what really works best for them.
Yeah, no, that makes perfect sense. And I'm glad you put it that way. Sometimes I think we forget to balance a theoretical risk with our actual lives and quality of life. And, putting it into context really helps them. And I love that you very much specify that it's the progesterone, right? It's women, estrogen doesn't increase breast cancer risk, does it?
Yeah.
And that's a big myth. Like, that's a huge myth that we have to dispel, that even in the Women's Health Initiative and every other study we've looked at, estrogen actually slightly reduces the risk of breast cancer, and that is statistically significant, which most people don't know.
Yeah.
I think I was going to ask you something else, but maybe you can ask me something.
Yeah, so that's kind of a lot of the risks and that breast cancer, I think, is the big one that women think about. But some of the studies are conflicting. There's different information on dementia, and how do you manage that conflicting information with your patients?
Yeah, so the other type of patient that we see who come into my office, at least, and probably into yours and many of yours, is the patient who says, "Oh, I need to have hormone therapy because it's going to make me live forever. It's good for so many things." And they want to hear about all the benefits of hormone therapy. And I love talking about the benefits of hormone therapy, don't get me wrong, but I think we need to be qualified in how we describe those. So what I often address is by system, basically. So I always start with bone because I can very convincingly say, estrogen therapy is good for your bones. It's good for your bones no matter when you start it. It helps hold that calcium in there, and there's really no downside from a bone perspective. In fact, it's one of its FDA approved uses is for osteopenia and osteoporosis prevention. Then we usually get into cardiovascular risk. And this is more complicated, right? The Women's Health Initiative told us that it increased the risk of stroke and heart attack in women. The Women's Health Initiative was designed because in previous studies, more observational studies like the Framingham study, women who started hormone at the time of their transition to menopause actually had a lower risk of cardiovascular events. And other studies have shown that as well. And really talking them through the window of opportunity around hormone replacement therapy and its safety window. There's also some question about whether conjugated equine estrogens versus estradiol have different cardiovascular impact in terms of benefit, and that's pretty complex data, but probably there is some difference. But really, what I tell women is if you're starting within 5 years of your last period or your transition to menopause, if you don't have a uterus and we don't have that signal, then you're very safe to start it. You're certainly not causing cardiovascular harm, and there may be benefit. If you're in that sort of 5 to 10 year window, it's neutral per the studies. So you're not causing harm. You're probably not getting a whole lot of benefit. If you're 10 or more years from your last menstrual period, we should not be starting hormone for you. We are increasing your risk of heart attack and stroke. And that has a lot to do with estrogen as it's clotting risk, because the cardiovascular system is shifted by that point. What we know about estrogen in the blood vessels is it's anti-inflammatory. So it prevents plaque buildup. It keeps things a little bit healthier and more pliable. By 10 years out, you've built plaque. And if we add something that might increase your clot risk, we're going to put clots on your plaque and they can go to your brain or to your heart. And really sort of laying that out for women helps them to understand the risk benefit ratio from there. Dementia, that's a tough one. I don't know how you attack this, but there's data on both sides of whether or not it's preventative for dementia. I tend to follow Dr. Lisa Mosconi out of Weill Cornell, and she feels like estrogen is beneficial to the brain, but it's really hard to prove that. And we know that people who have especially high risk, so people who have the APOE4 gene difference, they're not getting any better from estrogen. That's easy. That we're not preventing dementia with that. But the studies that say that estrogen may be beneficial to dementia are primarily long-term observational studies that show that women with the longest exposure to estrogen seem to have the lowest dementia risk. So that's including all of their cycling life, pregnancy, discounting breastfeeding, all those things. But the studies that have tried to be interventional, where they give people estrogen, we don't show that benefit. I think some of that is length of time of use. Probably if you're trying to prevent dementia, you need to start in that early window before 5 years, and you need to continue to the age of dementia, and nobody's going to fund that randomized controlled trial. So we really are struggling with different types of data and trying to patch it together. I think big meta-analyses have told us it's probably not risky if you start in that window. So at least I can assure them that we're not going to increase their risk of dementia if we start them in that 5 year window. If we start them after 10 years, we may actually be increasing the risk of vascular dementia. And again, another reason not to start at that point. And then we usually end up talking about our skin and our hair and our joints and our brain fog. And estrogen does help with all of those. It's partly that anti-inflammatory response. The brain has many estrogen receptors, so it tends to function a little bit better with estrogen around. So it's always this balancing act, right? We're trying to say, okay, here's the pluses, here's the minuses. How do those lay out for you as an individual? Speaking of how do we individualize treatment, I think there's this myth out there, right, of for lowest amount of estrogen for the shortest period of time.
Right.
How do you address that with women? Because it's written in some of the guidelines, right? It's there on paper.
Yeah, and that's a hard one to kind of move beyond, I think, but I think we're making progress with that. The Women's Health Initiative study coming out with such dramatic headlines and risks, the reaction to that was that we should let women transition into menopause without intervention. And in those cases where we really feel like we need to use hormones, we should use the lowest dose and we should try to transition women off it as quickly as possible. So that was not based on any data that showed that a lower dose was going to reduce your risk. So I think when I have a conversation with women about starting hormones, they will often ask me, well, how long do I continue that for? And I tell them, you're not making a commitment here. So, we're trying to get you to feel better. We're trying to improve some of your symptoms, prevent your bone loss down the road. And what we'll do is we'll get you started on them, get your symptoms relieved, adjust the dose as needed. And now you will often start people kind of in the middle so we can do a quick, let's feel better and then dial it back, or if we're not getting benefits, we can go up. And then we'll just weigh your personal pros and cons each year. So we'll just get you started, and then we'll kind of reevaluate at your annual visit each year. I also share with them that most women will start on their 50s, because that's, again, when people have the bothersome symptoms, and of course when the data supports starting hormones. And that most people will probably transition off in their 60s, but not based on any expectation that that's the safest thing to do. And I certainly have lots and lots of women who say, gee, I feel like I'm doing well in it, I want to continue. And if they haven't had a diagnosis of breast cancer or a blood clot, I support them in that decision. I think that we will probably, as time goes by, get more information to give us some concrete data in continuing estrogen, progesterone long term. There was a study that came out in May in the journal Menopause that certainly it provides reassuring information. It was a retrospective review of patients who were culled from Medicare data, showing that they had had prescriptions for estrogen or estrogen with progesterone. And they correlated that with diagnosis codes basically for different cancers. So they looked at lung cancer, breast cancer, ovarian cancer, endometrial cancer, and also cardiovascular events. And in those women who are prescribed hormones after 65, they did not find an increased risk of those events in the estrogen group and the estrogen with progesterone group. So obviously there's some gaps in our knowledge there, because we don't know if the women actually took them. We don't know the doses. We don't know how long they took them for. But I think the data certainly is supportive right now of continuing women on the hormones for as long as they want to. And so when women are wondering if they should continue on it and they feel like they need to get off, and I say, then great, let's taper off over several weeks and let me know how you feel. And some of those women, I don't hear from them until they come back the next year, and presumably they're doing fine. But there's a significant portion of that population, and them, that will call you within 2 weeks or 2 months and go, oh, okay, now I know the benefits I was getting from this, and I felt better. I just felt better. Sometimes it's not even something they can put their finger on, and they want to go back on it. And I think that we can feel very comfortable in allowing them to do that.
Yeah, and I think I have some patients in their 80s and 90s still on their estrogen. I usually lower their dose as they get older because their clot risk is increasing, and I always try to use transdermal, but it makes them feel better. And really, they've been on it since their 50s, and they're doing fine. I had one very funny 90-year-old come to me, and she's like, my doc said I had to get off of this, but I knew you wouldn't take me off. She's like, what's it going to do? Kill me? I'm 90.
Right. Yeah,
Like,
I feel
yeah,
like
I don't
anyone,
think
okay,
it's actually going to kill you, but yeah, I mean,
they can do whatever they
pluses and
want.
minuses, right? Oh man, I
So
love our
we've talked
patients
about
sometimes.
patients that are not candidates, patients with breast
Uh-huh.
cancer, patients with blood clots, and then there's a kind of clear contraindications, at least based on the information we have now. And then
Mm-hmm.
there are other people who kind of fall in a gray zone. So how do you
Yeah.
manage people who don't have clear contraindications? That's a tough.
That's a really good question. I think there are a couple different gray zones that I see a lot of. One is I have a family history of breast cancer.
Mhm.
So that one comes up a lot. They maybe been told by other providers that they're not a good candidate because their mother or their sister or someone in their family has had breast cancer and they're at higher risk. And it's, for patients who are very symptomatic, that can be really disheartening. And yes, we might try some of the other medications on the market to manage those symptoms. But what I tell them is that when you're looking at someone with a family history of breast cancer, we calculate their risk. That's their risk. What we call the attributable risk, or the risk that's due to hormones if we start them, doesn't change for them. They still get one additional case in 1,000 woman years from using estrogen and progesterone. And so we're not increasing their risk by any more than we're increasing any other woman's. They're just at baseline higher risk.
Mhm.
So that's often very reassuring for them, and they might choose to use hormones in that case. And also, I want to add, adding estrogen for those patients lowers their risk as well, as much as it does for anyone else. The other one is maybe a family history of clotting
Yeah.
disorder. They don't personally have one. Maybe they've never been tested. They've never had a clot themselves, but there's some concern there. And for some of those patients, if it's a strong family history, we might actually test them just to make sure that they don't have a higher risk. But generally, again, that's your family's history. It's not your personal history. Certainly in those patients, I would highly recommend using transdermal, because transdermal estrogen really does lower your clot risk. Especially, it's interesting if you actually look at the data, estradiol, which is much less potent than conjugated equine estrogens. Estradiol does not increase clot risk, whether used transdermal or orally under the age of 60. And then over 60, if used transdermally under a 0.05, we haven't seen any increased clot risk. So the only thing that I always qualify that with is that's all data from low risk women, right?
Right.
So taking that data and applying it to someone who maybe has a higher clot risk doesn't really apply. But if they're sort of in that middle ground where we don't really know that they do, it's just a family history, then that can be reassuring. Sometimes I see patients who've had stage 1 endometrial cancer, and so they've had a hysterectomy and a BSO. I always have them go back to their oncologist and check, but many oncologists actually feel that it's fine to use transdermal estrogen after that, especially if it was right around the time of menopause and they're very symptomatic. In patients who have a known cardiovascular disease themselves, I don't go down this pathway. And if someone's sort of in that tenuous middle ground, maybe they have a strong family history, maybe they have some increased risk themselves, I'll often use the ASCVD calculator and say, hey, your risk is actually quite high. Maybe adding a medication that can increase your clot risk is not a great choice for you. If you're already at a higher risk, we're not really preventing that risk increase. We may actually be adding risk for that. The last thing I always mention, because it comes up, and you've probably heard this too, oh, well, I have an increased clot risk because I have the MTHFR gene difference. And I'm always thrilled to reassure women that that gene does not cause clotting and does not change the way they process their folate in any way. If you're heterozygous, that does not prevent you from using hormone therapy. You can use it. I won't say the words that we call that gene test, but it is not something we need to be worrying about.
Diagnosis waiting for a disease, I think.
Yeah, I know, exactly. So I'm going to switch over real quick. We've been talking for a little while. I'm going to switch over to the Q&A portion of this, and I'm going to look at our chat and our Q&A boxes just to make sure that I'm answering questions as they come up. But anyone who's on the call, please throw things into the chat. I'm happy to answer questions. So can you comment on estrogen use and blood clots? A lot of questions. Yeah. So we started talking about that, right? And if someone has a personal history of blood clot, I think where it comes up the most, if they have a straightforward personal history of blood clot, I'm not going to start them on estrogen. Even though I know transdermal estrogen probably doesn't increase risk in low risk women, I can't translate that data to someone who's actually had a clot. And someone who's had a clot may well have vascular damage in the area of that clot that makes them even more thrombotic in that area. So it's a risk that I don't think is worth taking. I don't know about you, Holly, but what I often see is someone who comes in and said, oh, but it was a really small clot. And it was after I had surgery and I was immobilized and I'm not really at high risk and I'm really active now. Like, why should this prevent me from needing to take it? And it can be a little harder to counsel that patient. I don't know how you feel about that.
Yeah, I try to get the hematologist involved, and not all hematologists are going to be comfortable giving them a risk profile based on that history. But if it was something that was provoked that's not likely to repeat itself, I don't think it's unreasonable to do that, but they certainly have to proceed with caution and low dose and transdermal, and just be aware that we don't have all the data that we need. But sometimes a hematologist will come out and say, they think it's fine. And
yeah. My favorite though is when they come and they say, no, it's okay. It'll be fine because it was provoked. It was provoked by pregnancy. I'm like, then no, because that was provoked by estrogen. So maybe we shouldn't go down this pathway again. The nice thing is we have other options now, right? If someone's having a lot of symptoms, we have good new options. Have you used Veoza with anybody?
I have, yeah. So I've used it in breast cancer patients. I've used it in patients with someone who had deep vein thrombosis after a foot surgery. And I've been impressed that the relief of hot flashes has been pretty dramatic and quick. What I don't like is that we're not helping with some of the other things that people are dealing with menopause, and we're certainly not maintaining their bone density. But since hot flashes and night sweats are generally the things that people come to us with, acutely having disrupted sleep, which is probably leading to a lot of that irritability and brain fog, that we can at least give them something that can help them sleep through the night, that's safe and that isn't estrogen based.
Yeah. One of the other things that's been coming up more lately for me in patient interactions is patients are starting to hear that there's data for prevention of diabetes with hormone therapy. And, I had to go back and look at the literature because that
Mhm.
wasn't something that was in my wheelhouse. But I actually went to the 2022 North American Menopause Society hormone position
Mhm.
statement, and they say that there is level one evidence that women who have an increased risk of diabetes, so women with metabolic syndrome, PCOS, or prediabetes, that starting HRT at the transition to menopause can reduce the risk of diabetes by 17 to 30%, which is dramatic,
Yeah.
but also I think bears thinking about as one of the benefits because diabetes long
Mhm.
term is pretty harmful.
Did they comment on the mechanism by which that seems to confer a benefit?
So I think it's a metabolic effect. I think some of
Yeah.
it is maintenance of muscle mass
Yeah.
and how that helps
Okay.
us to use our insulin. It's a pretty big RCT that they quote, and they do call it level one evidence. So I was pretty impressed. And I don't think that's necessarily the reason to start hormones, but when you're always balancing those risks and benefits, which is what
Right.
we're doing, if
Right.
someone's at higher risk there and starting to see that risk play out, it might be a reason.
Yeah.
Um, what other things do people sometimes quote? What things do people believe are benefits of HRT that sometimes come into your clinic?
Yeah, I mean, there's people coming in with all kinds of different things, but the one that I've been impressed with recently that has made me more of a believer is the joint pain. I've
Mm,
had patients who are very athletic, cycling and running, and they come in and they
mm,
say, I can't exercise because my joints
mhm,
hurt. And I always tell people I can't be sure that that's what it's from. But I've started them on hormones and people
mhm.
seem to get better. And I know they've done studies where they found estrogen receptors in the joint capsule, and it's just very impressive to me that that's been one of those anecdotal things that I was not a believer, and I have
Yeah,
become more of a
I
believer.
agree with you.
Yeah,
You see it written places, but we haven't studied it well.
yeah,
And I was very much like you. And then I can't tell you how many people, and sometimes it takes a little bit more estrogen, I find.
yeah.
Like those are patients, if they have pretty bad joint pain, might need a 0.075 patch or even higher, especially at the first
Mhm,
transition. But yeah, no, I agree with you. I'm a total believer in that now.
mhm.
I'm going to go to the chat. We've got a bunch of things that I'm going to sort of take from the bottom up. Is the cardiovascular benefit of HRT enough for those close to menopause age to counsel towards using HRT? Um, that's a really interesting question. I don't know that we know.
Mhm,
In
mhm.
several studies, especially early ones, like the Framingham study, the nurses study, yeah, they had a significantly different risk of cardiovascular disease. And there are other studies out of Britain that definitely tell us that estrogen started at the menopausal transition seems to have that benefit. But most, if not all of those studies primarily used conjugated equine estrogens, which is not what we primarily use anymore. And there probably is a difference between an oral estrogen and a transdermal estrogen in terms of cardiovascular benefit. And the studies that are with straight estradiol used transdermally don't show as much benefit. It doesn't show more harm, certainly, but I think the jury's still out on exactly how that benefit plays out with what we use nowadays. Oral estradiol probably a little bit more than transdermal, but is there no benefit to transdermal? No, I wouldn't say that. But we're always balancing these things, right? I don't know about you, Holly. I very rarely ever prescribe conjugated equine estrogens. And my two reasons are that I think it is generated in a way that is extremely cruel. And so I don't like using it. My second reason is that there are 8 estrogens in there. And we don't know what all those estrogens really do in the body.
Mhm. Yeah,
Do
I,
you ever
I
use
rarely
it?
prescribe them. I have some patients who are kind of holdouts that have just been on them all this time, and
Right,
they don't want to rock the boat, and so just
right.
like some patients don't want to switch to transdermal if they've been on
Mhm.
something for a while. So I support their decision in that. But no, it's not my go-to. It's not my primary prescription at all. It hasn't been for a long time.
Here's what I'm gonna shoot to you. There's a question that says, for women who are good candidates for hormone therapy, is micronized progesterone your progestin of choice? How often do you suggest an IUD or other progestins?
Yeah, so micronized progesterone is definitely my progesterone of choice, and that's based on the French data that showed that with the first 5 years of use, they did not see an increased risk of breast cancer, and after that, the risk was comparable to medroxyprogesterone acetate. So the data that we have now supports using that because of the breast cancer benefits. As far as an IUD goes, it's not sort of officially FDA approved for endometrial protection for use of estrogen, but I certainly do use that in some of my patients who I feel like can understand the subtle nuance there. So if someone is transitioning into menopause and they're 47, 48, and they still have an IUD, and we're within that 5 years of use when it's still indicated for bleeding control, so we assume that there's enough progesterone to protect the uterus, I will let them use that with a low dose patch. If I'm less than 0.05, I'll let them use that. And that's really based on just my personal preference and comfort. But I do think the data is supporting micronized progesterone as the primary endometrial protection. Yeah.
Yeah, I'm gonna complicate that data. The
Yeah.
IUD has been looked at for endometrial protection to 5 years. You're absolutely right. I always like to add on, it has never been looked at from years 5 to 8, and I know it's approved to 8 years for contraception, but we do not have any data that it's good enough for endometrial protection. So I do recommend my patients change at 5 years if they're using it. The IUD does not protect you from any breast cancer risk. So we know that women who use Mirena IUDs for long periods of time actually have a slightly increased risk of breast cancer, just like using levonorgestrel orally. So it's probably a little bit better because the dose is maybe slightly lower, but there is some systemic effect. And so we're not escaping that risk
Right. Right.
by using an IUD. And then the last thing I always add in is that micronized progesterone is slightly more associated with what we call nuisance bleeding. It's not as strong a progestin as the MPA or the levonorgestrel or any of these other progestins. And so some women will just bleed more on it. You might need more of it. But if you look at long-term studies, it may have slightly less protection against hyperplasia and endometrial cancer than some of these stronger progestins, but that's over extremely long-term use at very low doses. So as long as you're watching and if they're having bleeding, you're monitoring and adjusting dose appropriately, then yeah, I think it is the progestin of choice. The other thing I always go back to is that it has really good sleep effect.
People find it calms them, and So if I have to go up to 200 milligrams to control some nuisance bleeding, people are very happy with that because it does seem to
Yeah.
promote sleep not in a Benadryl kind of way, but in a just calming, go to sleep, and I think that's a tremendous benefit from the
Yeah,
promethazine.
no, I agree with you. And we don't get that from the Marina, unfortunately. There's a question about lots of chatter on social media promoting the use of testosterone for low libido and low energy. How do we approach that conversation? I'm going to give a very brief answer to that, but point everybody back to us in a couple of months. We're doing a whole talk on libido and sexual function, and we're going to address testosterone at length in that one. So please come back for that webinar. Testosterone does not decrease with the menopause. Testosterone is on a slow decline throughout our lives from our 20s when it's at its peak to our 80s. But there is no change in it at menopause. And in fact, in perimenopause and early menopause, we probably actually read a little bit more of it. It's why we're seeing chin hair and acne and weight gain around the middle because our sex hormone binding globulin is going down. So we're actually seeing a little bit more free testosterone. We can use testosterone well managed, keeping it in a normal female range, which is under 50, for a side effect, which is it makes you slightly hornier. And so there's pretty decent data for women in the perimenopause, postmenopausal range that it might be beneficial for that. We just need to be very careful with it and use good FDA regulated methods for getting it to them. Using testosterone for energy is not indicated. And if you're using testosterone for energy or for muscle building or things like that, then you're using it as a doping mechanism. And you need to use more than the normal female range to get that impact. And so you're going to have risk of beard growth, male pattern baldness, lowering of the timbre of the voice. All of those are irreversible. If you cause those changes, you can't take them back. But it probably has impact on cardiovascular health if you're using it in male ranges as well. So we do not do that. And that is not a recommended use for testosterone. And it is not a study proven use for testosterone. I think the other thing I always like to mention whenever testosterone comes up is that sending a free and total testosterone on a woman, you're very likely for it to come back as negative or very low. That's not because they are low. That is because the classic free and total testosterone that is sent in LabCorp, Quest, and any of those labs is valid only at male levels. It is not validated under 50, which is where women usually live.
Mhm.
So if you have a reason to test testosterone, which we really don't, we know it's still there, you need to send liquid chromatography screening to get an accurate reading of women's testosterone. So I tell women I don't send the test as to see if they're low, because that's not going to help me. It doesn't tell me really anything. The only reason I send the test before I start them is to make sure they're not too high.
Yeah.
So, if they have a testosterone of 100, it's going to come back there because that's actually in the valid range.
Mhm.
So that's how that's the quick and dirty on testosterone as hormone therapy.
Yeah. Yeah.
We have a question that asks, can you comment on the appropriateness of telemedicine versus in-person care for those gray zone patients whose candidacy for HRT is not entirely straightforward? What do you feel about that, Holly? How do you
I
feel
mean,
about telemedicine for this?
yeah, so I mean, I found telehealth to be very amenable to addressing patients with all
Mm-hmm.
kinds of menopausal concerns. And, there's going to be rare patients that we want to do labs on, but that's not going to be typical. And we do have ways to get labs done if we want to do that through the telehealth system.
Right.
So I found that it's tremendously helpful. And I haven't encountered any situations where I have a patient that don't feel like I'm able to manage them online. Most of them will have somebody that they can go back to, a family doctor, if there are other things that need to be addressed, and just the
Mm-hmm.
routine screening that they need. But no, I think the telehealth platform has been a great way to reach a lot of people and care for them appropriately. Yeah.
No, and I agree with you. And I think we've had a few patients who've had postmenopausal bleeding, and we just hook them up with a local gynecologist or their primary care doctor who does a biopsy. Some of these patients say someone who I've had a few patients come to us thinking that we prescribe hormones for everybody, and they've had hormone-sensitive breast cancer, and I tell them that's not appropriate for telemedicine. We don't have the right relationship to do that. So certainly someone who's very high risk, no, that wouldn't be appropriate via telemedicine. But a lot of this is just conversation. It's risk
Right.
benefit discussion, and telemedicine is great for that. I also think it allows for expert opinion in areas where maybe that doesn't exist, right? So if they're in a very rural area where they just don't have access to this kind of expertise, it actually gives them access, which is wonderful. Couple questions on progestin dosing. Especially for micronized progesterone. So how do you dose your micronized progesterone for continuous versus cyclic use? And I'll tell you, I use very little cyclic progesterone because nobody wants to have a period in
Right.
menopause.
So my goal is no period. So I would typically, what I do far and away most commonly is 100 milligrams a day at bedtime, just continuous dosing. It's much simpler to dose it continuously. Now, there's certainly going to be women who are transitioning into menopause and still having fairly regular periods or fairly frequent periods. And in those patients, while I would love for them to not bleed, I would be more concerned about them bleeding irregularly and unpredictably. So those are the patients that I will often do cyclic hormones, in which case I do 200 milligrams for 14 days out of the month. And I just have them typically do it by the calendar month, the 1st through the 14th, anticipating a withdrawal bleed towards the end of the month. And I tell them they might bleed irregularly at first, and that this phase will go away, and we'll switch it to continuous. And then a lot of times they come back and they say, well, gee, I'm not bleeding. And so then we just go to continuous. So pretty much everybody gets continuous 100 milligrams unless they're really having fairly regular periods when we start. And then I'm trying to override their cycle and be able to manage it with a regular period, which for the most part has been successful.
Yeah. I occasionally use continuous 200 milligrams if I'm putting someone like a 0.1 patch or higher. And those are often my premature ovarian failure patients who really are very young and need more estrogen. I sometimes use it if someone's having nuisance bleeding on 100 milligrams because some people just don't absorb it that well. So I might go up to 200. But yeah, I practice very much how you do. There's also a question here about other progestins. So things like Slind or Micronor, and are they adequate to counter? And the answer is yes. These are contraceptive level. So they're actually probably even higher than what we're talking about with micronized progesterone. And actually, I have been using Slind with a patch in my perimenopausal women who don't really want to be on birth control, but we need to control that nuisance bleeding that's coming up or those really big flooding periods. Sometimes that works a little bit better than using full HRT at that point. Someone's asking, do you ever use Combi Patch or Clamera Pro? How
Are
about
they
you?
still available?
Yes,
I
they
haven't,
are.
yeah, I haven't. The last time I tried to prescribe Patch, nobody had it. So,
No, there's that.
yeah, I
Yeah.
mean, I think it's a great option. Again, it's not the micronized progesterone. So, I think the data, I feel a little bit more comfortable with
Hmm.
micronized progesterone now. I like the idea of one patch, you're not juggling different things.
Hmm.
But most people are happy to take that Prometrium at bedtime because it seems to help them sleep. So I don't know. Are you still using it?
Yeah, so I've used it occasionally. I find more spotting with it. I
Yeah.
see people have more nuisance bleeding with it because all progesterones are a little harder to get in through the skin, just because of the size and the shape of the molecule. And a Climera Pro I haven't really used because I don't really it's CEE and I don't tend to use CEE.
Yeah. Right.
But I don't think it's a bad idea.
Mhm.
It's just different risk
Yeah.
estimating when you're
Yeah.
counseling. Someone is asking, how do you feel about Duav? So basidoxifene estrogen.
I
Have
can't say
you
I've
ever
had
used
too many
it?
I have, yes, and it's nice because it's a one pill. You don't need any
Hmm.
progesterone. I think the data supports it. Um, Again, it was unavailable for a while there, and
Right.
so it's just
For
been
years
kind
we
of
couldn't get it. You're
right,
right.
exactly. So it's just kind of fallen out of my armamentarium. Not that I think it's I think it's a very reasonable option. It's just not my go-to. I like the generic estradiol patch and
Mhm.
Prometheum. It's very accessible. It's very easy to use. Um,
Yeah.
and it has multiple dosing
Right.
ranges.
The one time I've felt good using Duav, again, CEE, not my favorite
Right.
medication, but the one time I have used it and actually felt good about it is in patients who maybe have like PASH or atypical ductal hyperplasia of the breast. It's not cancer. It's maybe higher risk, but kind of
Mhm.
debatable. And so having the basidoxifene in there, which is anti-estrogen at the breast as well as the
Yeah.
endometrium, maybe makes me and them feel a little better about it.
Mhm.
Um, so I can see a role for it there.
I don't
But
think it helps with vaginal
it's
dryness, though.
rarely covered.
Yeah. Yeah. And it doesn't help with vaginal dryness. I mean, it doesn't
No, it
target.
does not help with vaginal. In fact, you have to treat the vagina separately. It behaves like
Right.
tamoxifen at the vagina. So you're
Right.
going to be adding estradiol to the
Right.
vagina anyway.
Yeah.
Yeah. Let me scroll through and see if there are any other questions for us. And please continue to give us questions. These are great. Um, no, that looks like, oh, wait, here we go. Since OCP ethinyl estradiol is not as good as treating vasomotor symptoms, what's your approach for the perimenopausal patient who's starting to have some vasomotor symptoms and wants to keep birth control? I'm going to start and then you can add in other things.
Yeah. Yeah.
So I find that most women do fine with ethinyl estradiol for their vasomotor symptoms. If they've been on it for
Mhm.
a long time, they really just don't experience them. But some do. And for some, using traditional birth control pill with ethinyl estradiol really doesn't attack them very well. I've been using Nextstellis, which is estetrol, and sorry, tell me the progestin. Brain fart. It's my menopause brain.
Just Veronone. It's just Veronone.
Thank you. Drospirenone. Sorry, guys. Estetrol, drospirenone. So estetrol or E4 is a much more, it's called a NEST or a naturally occurring estrogen selective therapeutic.
Mhm.
It's estrogen we used to make in our fetal livers. We don't make it in adult life, but the body is used to it. And the nice thing about it is it works at the nucleus much more than the cell wall. So you get fewer side effects, which tend to be cell wall effects, and really good effect, especially in the brain from its nuclear response. So I've had good luck with that in terms of
Mhm.
symptom
Mhm.
control. Have I ever added a patch to an OCP? Yeah. I mean, you're not going to do much harm. They have strong progestins in them.
Right.
So adding a
Right.
little bit more estrogen isn't going to hurt anything. And it's the progestin really that's giving the contraceptive effect. I think it's really good to point out that if they are perimenopausal, they can still get pregnant. And please keep them on something contraceptive.
Right. Yeah.
Probably
I think,
another route you go down is this is a great time for an IUD and a patch.
yeah. When women are transitioning into menopause, because irregular bleeding is so much a part of that,
Right.
it's just such a nice way to
Hmm.
avoid bleeding that leads you to do an ultrasound and an endometrial biopsy. So if you can just shut that lining down while you transition through that irregularity, I just think that's a really nice thing to do. And then certainly you can do a patch with that, and then you're providing contraception and you're controlling the bleeding without worrying about cardiovascular risk from birth control pills. as you
No,
go.
I totally agree. Just outside of the contraceptive effect, people in early perimenopause are still bleeding pretty regularly. They can have really horrendous periods.
Yeah,
And patch and micronized progesterone often aren't enough to control that. You need something like a birth control pill or an IUD.
yeah, yeah.
How about the combo estradiol progesterone pill versus transdermal oral progesterone? Um, you know, I think the combo pill you're talking about is Bijuva, and that has estradiol and micronized progesterone in it. It's a really interesting product. It's actually, I don't know if you ever cut one open, but there's a little dividing line, and they've micronized both the estradiol and the progesterone. It's a
Mhm.
great little device. You know, they did early studies. So I knew the OBGYN who created it, created by an OBGYN. Thank you very much. Also in Bexy. Um, And they did early studies showing that the use of Bijuva did not alter liver function parameters around clotting. They did not have the funding to study out to actual clot outcomes, right? So they can show that it doesn't increase the clotting factors of the liver, but what they couldn't show was, does it
Actually, yeah,
actually safe as transdermal for clotting?
right.
That being said, any oral estradiol doesn't increase clot risk in anyone under 60, as far as we can tell. Estradiol is just a different beast than CEE. So keeping that in mind, I think Bijuva is great. Again, the only barrier there is coverage. Like I have yet to, coverage can be really difficult,
Right.
but I'm seeing more and more. So those drugs were all bought by Maine Pharmaceuticals. And Maine Pharmaceuticals has a lot more lobbying power with the insurance companies. So we're seeing better and better coverage for things like Bijuva and Imvexi and Annovera, which were the three big
Mhm.
products that they purchased from the company. I think that's the last question. Anything you don't think we've talked about today,
No, we've covered a lot of ground. I'm excited that that it's
Holly?
become
We have.
something that we talk about. It's
Mm-hmm.
having practiced for so long, it's something that just people didn't talk about, and it's exciting that
I
we've got
know.
support now with new data coming out and with NAM's position statements and things like that that allow us to bring this back to women, because I think it's just
Mm-hmm.
a shame that women have had to kind of suffer through this for so long, and not just the suffering, but there's potential significant benefits to being on
Yeah,
estrogen
no, I
in the long
agree.
run.
There's potential health benefit, especially in our patients who are high risk for osteopenia, because you can use this for a very long time to support bone, right?
Mhm.
Whereas, there's question about how long you can actually use a bisphosphonate, especially with the jaw necrosis and things.
Right.
And some of the other medications really have a limited, you're jumping medication to medication. Um, Someone asked if this is being recorded. It is indeed being recorded, and everybody who registered will get a copy of the recording, whether or not they could make it. So yes, you can absolutely listen again and share it widely, please. This is free education for anyone. So if you think of somebody who you think would benefit from it, please share the recording. Um, I think that's it for today. So same time and place next month. Next month is on the third Thursday at 2 p.m. Pacific, 5 p.m. Eastern. Um, it's going to be a discussion of perimenopause. It's me again. Sorry, guys. This time I'll be talking with Amy Vodich. She is my co-author. We're actually writing a book on perimenopause, but she is from Stanford University. She runs their menopause clinic, and we're going to talk all about perimenopause and that such a fun time of life. Anyway, thank you everybody for coming. Take care.
Thank you.
Mhm.